this spike protein attaches to the host cells, and the other proteins also have different roles. For example, the membrane protein is responsible for the assembly of viral particles. The envelope protein plays a role in the pathogenesis, and the nucleocapsid protein packs the viral genome into a ribonucleoprotein complex, and also plays a role in the viral genome replication and the cell-to-cell signaling pathway. I understand that on the call we have medics and the non-medics. So forgive me if the terminology is not very familiar to you. I'll just try and make it as simple as possible. So the incubation period for this disease, incubation period is the time between exposure to the virus to the time of symptom onset. It's on average 5 to 6 days, but it varies from 2 to 14 days. So people can show symptoms anywhere along that period from 2 to 14 days. And remember that individuals have been shown to be most infectious just about a day prior to onset of symptoms. So it's difficult to tell who is infectious at each time along the incubation period.
How are you, my?
The mode of transmission we all know now is through respiratory droplets, but we also know contact with surfaces if the virus has landed there through the aerosols and droplets. And then for medical workers, the aerosol generating procedures, for example, bronchoscopy, induction of sputum, intubation, airway suctioning, all those will have high risk of aerosol generation, and these aerosols will transmit the virus from an infected patient. In indoor settings where there is inadequate ventilation, it remains highly infectious as aerosols for long hours, and it can travel for tens of meters before landing on surfaces, where somebody else might pick it up because it survives for up to 6 days. The route of entry we know is through the respiratory mucosa, so the eyes, nose, and mouth, where the virus gains entry through the SCE2 receptors in the respiratory epithelium. So if an infected person, if somebody gets in close contact with an infected person who is releasing these viruses in aerosols or in airborne sneezing and that kind of material, then the uninfected person will get infected through their respiratory system, and that is the eyes, the nose, and the mouth, okay, through the mucosa. So the virus binds to the SCE2 receptors, which are found in the epithelium, and then it goes through a series of pathways, as shown on this diagram. If we look at A on the picture, on the side labeled A, we see the spike protein binding to the cellular receptor SCE2 receptors, and that binding induces conformational changes that allow the virus to get inside the cell. So internalization results in uncoating of that viral genomic RNA into the cytoplasm, where other changes take place and manufacture of the viruses takes place with viral assembly, later on resulting in newly formed viral particles that are subsequently released out of the cells via a process of exocytosis. Then on the side, on the right-hand side of the diagram, we have showing us the pathophysiology of the disease, where we have initial replication of this virus taking place in the respiratory tract, have it migrating and virus replicating in the lung cells, the lung pneumocytes, and shortly after that, we see that an individual may get a viremia that disseminates the virus throughout the body through the circulatory system. So the blood circulatory system then will transfer the virus to other parts of the body. It's important to remember that other parts of the body also have the receptors. The SCE2 receptors have been found in the GIT, that is in the liver, in the gut, but also in the heart, the pancreas, and that enables the virus to cause damage in those organs, as we shall see. It's important for us to know that 95% of people who get infected with this virus will get mild to moderate symptoms and eventually cure, but we know that 5% will go into critical illness with multi-organ damage. So the pathophysiology of the disease, before I discuss the management itself, is important for us to understand. As I have said, COVID-19 is primarily a respiratory disease, but it can have multi-system involvement depending on what transpires after the virus has gained entry into the host cells. So the immune response that follows after one is infected with virus that involves both the innate and adaptive immunity, with subsequent cellular and humoral immunity coming into place. And the cellular immunity will see us getting the cytokine production. So we'll see these cytokines, chemicals that are inflammatory, pro-inflammatory, cause an inflammatory response in the body, as we shall see in the next bullet. But also we see the B cells beginning to produce antibodies for purposes of neutralizing the virus, but also bringing on board other immunological pathways that help to clear the virus from the body. So as we all know, for many viral infections, our bodies are able to clear these viruses from the body, depending on how virulent that particular virus is. But this is not the case with COVID-19. The body, yes, tries to fight, gets the cytokines up, the pro-inflammatory and the anti-inflammatory cytokines come into play, antibody production begins. But we know that for a small group of patients, we see these patients mounting an overwhelming hyperimmune pro-inflammatory response, meaning the immune response is an exaggerated response, and it is a pro-inflammatory response, meaning it promotes the inflammatory process going forward. And that overwhelming reaction has been shown to be associated with massive production of the cytokines, and that is what is called the cytokine storm. These cytokines include things like tumor necrosis factor alpha, the interleukins, particularly interleukin 1, interleukin 6, interleukin 8, and these have been shown to be mostly produced towards the first week of infection. So, and that is when the most dangerous period for many of these patients, when the cytokine storm sets in. Then we know that there's higher level expression of the SCE2 receptors in the adipose tissue, the fat tissue. But we also know that obese individuals who have a lot of this adipose tissue also are in a state of hyperinflammatory state. And this increases the risk of the cytokine storm and end organ damage. So we have seen many individuals who are obese coming down with severe and critical disease. And this seems to be the reason why they do so. Then these receptors, where the virus gains entry into the host cells, the SCE2 receptors, have also been isolated from the endothelium within the blood vessels. They have been isolated in the gastrointestinal tract, including the liver, the pancreas, as well as the urinary system, the kidneys, the kidney tissues. So this explains the multi-system presentation, because the virus is able to gain entry into the cells of those organs and cause damage. For example, we have seen many of these patients coming down with new onset hyperglycemia, even those who were not diabetic before, presenting with new onset diabetes. And those who had diabetes before and were well controlled, coming in with very high sugar levels, meaning they're out of control. Basically because this virus has gained entry through those receptors and is causing a lot of pancreatic cell damage and causing inability to secrete insulin, which is responsible for sugar metabolism. So these patients come in with new onset diabetes or worsening of an existing diabetes. The hyperimmune pro-inflammatory response, that is from the cytokines, produces multi-system manifestations. And I think this is what Dr. Ikirapa was referring to, multi-system manifestations. And these present as increased vascular permeability. As you remember, I said there's damage to the endothelium. So when there's damage to the endothelium, we get increased permeability with leakage of fluid, causing secondary cardiovascular instabilities. So we see patients coming in with pulmonary manifestations because of this damage to the endothelium within the blood vessels of the pulmonary system. But we also see a hypercoagulable state. That is a state that increases blood coagulation, thrombosis. This leading to venous and arterial thromboembolism. Remember, I said there's endothelial damage, and that damage sets off a cascade that results into increased thrombosis, and patients then become prone to getting venous and arterial. Sorry, I don't know how I got muted, and I don't know when you stopped hearing me. Dr. Ikirapa, when did you stop hearing me?
No, you can just continue. It was just
okay.
Now.
So the hypercoagulable state, and we shall see that this is the reason why patients with severe and critical disease require to be given anticoagulants as prophylaxis for this thrombosis. However, this doesn't happen in patients with asymptomatic or mild disease, and therefore there is no need to give patients that kind of treatment. Then the tissue inflammation and destruction leads to acute respiratory distress syndrome, and this is the worst form that has been shown to be responsible for death of majority of patients. And indeed, post-mortem done by Dr. Kalungi and other pathologists here and elsewhere has shown that this is what kills majority of patients. So they get a lot of pulmonary congestion, and they get a lot of secretions within the respiratory system. And the secretions are very thick. Patients are unable to get these secretions out. And this causes kind of a solidification of the lungs. The lungs are not supposed to be solid. They contain air in a normal state. But because of this thick fluid from the inflammation and destruction, the lungs are very congested and they are more or less kind of in a solid kind of state. So oxygen exchange, venous exchange, gaseous exchange across the pulmonary tissues is very difficult. And this is what causes death in majority of patients. So having gone through that pathophysiology, just to summarize the treatment modalities available. So as I said, this is the virus. And with this virus, we do not have a magic bullet in form of treatment. So there is no one single drug that has been proven to treat COVID-19. We've had a number of trials on different antiviral drugs, lopinavir, ritonavir, and many other antiretroviral drugs, but to date, we don't have a magic bullet. Remdesivir was shown, as I will show you in one of the slides, to be to be beneficial in some patients. However, there's still some controversy, as I'll show you, but the recovery trial, the remdesivir trial showed that it had some benefit. I'll discuss that a little while. So other research done on suppression of the harmful effects. So apart from getting an antiviral medication to hit the virus and clear it out of circulation, there is supportive management, and that is the basis for treating COVID-19 currently. And this management is really hinged on suppressing the harmful effects of the cytokines that I explained. And from the recovery trial, we see that one steroid, dexamethasone, was shown to be beneficial, but the benefit was shown in patients who required oxygen therapy. So this dexamethasone is not really necessary for patients with asymptomatic COVID-19 who have tested COVID-19, SARS-CoV-2 positive, but are asymptomatic. So we do not have to give them this dexamethasone, nor is it used for patients with mild disease. The other one is the anticoagulation. As I explained, these patients are in a hypercoagulable state, those with severe and critical disease. So they need anticoagulation prophylaxis to prevent them from getting this thrombosis. Then there's some anti-tumor necrosis factor treatments and some inflammatory, some drugs that have been used to stop the inflammation, as we shall see later on in the in the later slides that have been tried, and some have shown to have some benefit. However, those are not also available in the majority of our settings here. And these include things like interleukin-6 inhibitors and tocilizumab. So as I mentioned, dexamethasone has proven to be beneficial, and that is one of the drugs that we have incorporated in our treatment guidelines, and we are currently using for patients with severe and critical disease. Sorry, I think my slides have my. Okay, so having gone through the pathophysiology of disease and seen that majority of patients will remain either asymptomatic after being infected, or they'll just come down with mild disease. And we see that about 15% of these individuals will get severe disease, and another about 5% will get critical disease requiring intensive care treatment. What puts individuals at high risk for severe disease has been shown to be some of these factors here on the slide. So older individuals above 65 years of age, patients with underlying comorbidities, including heart and cerebrovascular conditions, for example, those who have had a previous heart attack, who have had a stroke, then patients with diabetes, patients with sickle cell disease, cancer, liver disease, HIV, especially those who have advanced immune suppression with AIDS, lung diseases, for example, asthma, tuberculosis, and chronic obstructive pulmonary disease, kidney disease, severe acute malnutrition, obesity, pregnant women, and smokers. So we have seen a number of pregnant women coming in with severe disease, and they have been added to the risk group, the groups at high risk, as well as smokers have already been defined to be at high risk because of the effect of smoking and all the nicotine that it contains on the respiratory epithelium, where I said the receptors for the virus are. So the symptoms include the common symptoms, which include fever, a dry cough initially, starts off as a dry cough, but as you go along the course of disease, it tends to get wet. Then myalgia or fatigue, extreme weakness with joint pains, shortness of breath, sore throat, and headache. And other symptoms include things like flu-like symptoms, diarrhea, nausea, loss of smell and loss of taste, muscle aches and difficulty in breathing, and eventually some patients will get a DIC kind of manifestation. So this picture shows you that basically every system can be affected, and this next one shows the extrapulmonary manifestation. So as I said, the disease is mostly a respiratory system disease, but some patients get extrapulmonary manifestations. So in the nervous system, patients may get headaches, severe headaches with dizziness. They may get confusion with encephalopathy. They may get anosmia. They may get stroke. Then in the circulatory system, they get thromboembolism, where they may get a DVT, pulmonary embolism, or they may get catheter-related thrombosis. The disease also affects the liver, where you see elevated transaminases and elevated bilirubin. The kidneys will also be affected for some patients, where you get acute kidney injury with proteinuria and hematuria due to damage to the membranes in the kidneys. In the GIT, we'll see things like diarrhea, abdominal pain, anorexia, nausea, and vomiting. In the endocrine system, I described the hyperglycemia and diabetes getting out of control, and some patients coming in with diabetic ketoacidosis. So any patient with diabetes is at very high risk. And then the cardiac system, the heart is affected. It's one of those organs where patients have been shown to have injury to the myocardium, that is the heart muscle, coming in with things like myocarditis and arrhythmias, and coming in with cardiogenic shock and other manifestations. Then in the skin, some patients also have been shown to come in with skin manifestations, including things like petechiae, livido reticularis, and erythematous rash. So this chart summarizes the spectrum of disease of COVID-19. And as you can see in the first column, that is the category of disease. And we see the characteristics in the second column. So as I said, some patients will get infected with the virus, but they will not come down with the disease, so they remain asymptomatic, while others may be pre-symptomatic, meaning they are along the pathway to eventually showing symptoms, but they may not be showing symptoms at that particular point in time, but eventually they may show up with these symptoms. So these have tested positive for SARS-CoV-2 virus, but they do not have symptoms. Then those with the disease with symptoms are categorized currently as mild, moderate, severe, and critical. And we have the mild illness being categorized as patients with mild symptoms, which have varied symptoms such as fever, cough, sore throat, malaise, that is weakness, headache, and muscle pains. These patients do not have shortness of breath. They are not dyspneic, but they may have abnormal imaging. If you do a chest X-ray or CT scan, you may find that their lungs are affected and they have manifestation of disease in the imaging, but they actually are categorized in this category of mild illness. And this is the category that we are currently managing in the home-based care setting, as we shall see. Then patients with moderate disease are those whose oxygen saturation is above 94%, and they have a lower respiratory disease. So they have a moderate kind of pneumonia, as evidenced by the lower respiratory disease, evidenced by clinical assessment or imaging. But they have moderate illness, and currently these patients can also be managed at home with their oxygen saturation above 94%, as we shall see. The next two categories are the severe illness, where we see patients beginning to desaturate at less than 94%, and they're getting increased effort in using increased effort of breathing. They're tachypnic with a respiratory rate greater than 30 breaths per minute, and they have lung infiltrates that are covering over 50% of their lungs. Then the last class is those with critical illness, and those are the ones who have respiratory failure. They may be they have respiratory failure, they have septic shock, and they may have multi-organ dysfunction. So they may have a single or multi-organ dysfunction. So, and again, I repeat, majority of people have mild illness, while about 14% develop severe disease requiring admission and oxygen support, and 5% develop critical illness requiring ICU care. For home-based care guidelines for Uganda, we are taking the people who are asymptomatic, pre-symptomatic, mild illness, and moderate illness. Anybody with severe illness or critical illness, or anybody who has high risk factors for severe illness and critical illness is managed in the hospital setting. So this one is just to show you the diagnosis, and I will not spend too much time. We all know about the nasopharyngeal swabs. Many of us have had these swabs repeatedly. The throat swab is another one, but we know that the nasopharyngeal swab has higher sensitivity. And this swab is taken for PCR, real-time PCR, where they will demonstrate presence of the viral nucleic acid. The Ministry of Health has also rolled out the rapid antigen diagnostic tests, and this is to be used for screening purposes for symptomatic alerts and symptomatic contacts of confirmed cases. Then it's also used for diagnosis in patients who have COVID-like symptoms who are presenting at health facilities. Then the other category is for symptomatic cases in congregate settings like the prisons and schools, where it's suspected that they are exposed to known cases at high risk to establish an outbreak in those congregate settings. So any RDT positive cases from the mentioned population will be considered as COVID-19 positive, and they should be managed accordingly, not requiring additional PCR, and that is the current Ministry of Health guideline. So this slide is to show you the typical bilateral ground glass appearances, opacities on the chest CT scan that are seen in patients with COVID-19. I'll not spend too much time on that. The arrows are showing you where the ground glass opacities are. And this is an X-ray of another patient, still showing you the infiltrates bilaterally. And that is the same picture over there. So radiology is also used in diagnosis of COVID-19 pneumonia. And as I said, demonstrating the infection is by the PCR and the rapid antigen test. But for clinical care and diagnosis, there are radiological imaging modalities, including the CT scan, the chest X-ray, and the chest ultrasound scan are used. So I will go into the home-based care presentation now. And as we go along, if anybody wants to add something, I think Dr. Ikirapa, you can allow them to put up their hand to speak. And we shall not go into details of hospital care, although I have mentioned a little bit about that. So if we can define the key terms for home-based care, what is home-based isolation? This is when a patient confirmed to have COVID-19 is mandated to restrict activities and movements outside their home unless when seeking medical care. And during the entire process of home-based isolation, the individual should not go to public places like workplaces, schools, markets, churches. The patient should also not use public transport like the taxis, the buses, and shared border rides. This is basically to stop the chain of transmission from that infected individual. And what is home-based care? This is when the COVID-19 positive patient is provided the required care directly in their home by a caregiver who may be a family member, a friend, or a member of the local community, while cooperating with the advice of the health workers and strictly following the home-based isolation standards and other COVID-19 prevention and control measures. So that is our definition of home-based care. And according to our guidelines, there are key steps and procedures for consideration for one to be deemed fit for home-based care. And according to the WHO guidelines, the decision as to whether to isolate and care for this person in the home-based setting depends on three factors. One, this patient needs to be evaluated clinically, okay? As I said, I mentioned the risk factors for severe disease. So it is very important that patients get clinical evaluation from the start. I know that many patients feel unwell, they move to the labs, they get a test, and then they decide that I'm going home for home-based care. That is not ideal. The ideal thing is for you to get in contact with a health worker so they can assess you for your risk for development of severe disease or your risk for presence of already existing severe disease at that time of diagnosis, so that you get into the right setting. Then the second step is evaluation of the home setting. This is also very important for two purposes: to ensure that the people in your home environment are going to be protected in terms of infection prevention and control, as we shall see, but also for you, the patient, to ensure that you're going to be able to continue receiving adequate supplies like food, the medication, and that there's possibility for you to get to the earliest health center in case of worsening of the disease. We have seen patients presenting very late, up to even about 10 days or 2 weeks later, because they have been in the home-based setting and they have delayed to seek care due to several reasons. And many of these patients end up dying because of that delay. Then the third aspect is the ability to monitor the clinical evolution of this patient's disease at home. So it's important that there's somebody in the home, a designated caretaker, to be able to monitor this patient to ensure that at the earliest onset of signs of severe disease or danger signs, this patient can easily be evacuated out of the home into a health facility. So home-based care may be considered for an adult with this confirmed or suspected COVID-19 if the patient has no symptoms or has only mild symptoms. If the patient is not at high risk for developing severe disease, and if, for example, a COVID-19 patient was hospitalized but they are yet to complete their recommended period in the hospital, but the clinician deems fit that this patient is able to go back into their home setting. So those are the three kinds of patients who can go into the home-based care. So this eligibility for home-based care should be made by a health worker for purposes of avoiding patients making their own diagnosis and then getting into the home and getting worse and coming to the hospital very late when they cannot be treated adequately to improve their prognosis. So that is absence of symptoms or only presence of mild symptoms, no known risk of developing complications or progressing to severe disease. Risk for progression to severe disease is very important. For example, I mentioned diabetes. Patients with pre-existing diabetes are at high risk. So if you don't evaluate them at the start, you don't know their blood sugar control, you don't know their blood pressure control, and they're just going into the home-based setting. Next, you'll see patients coming back to the hospital with diabetic ketoacidosis, and that is what this statement is trying to avoid. Then patients who live in a home that meets the criteria for home-based setting, that is another criteria. And then the patient should demonstrate understanding of the rationale of why they need to stay in the home when they are sick until they are cleared for discharge or de-isolation, as we shall see. And they should also express willingness to comply with the home-based isolation guidelines until discharge or de-isolation. This is really to stop the chain of transmission to other community members. So any patient assessed from the treatment center and sent home after being found eligible for home-based care. So basically, I'm trying to emphasize the need for initial assessment and patients not taking themselves into home-based care without that assessment. And once they're in home-based care, what should we look out? These are some of the danger signs that a person monitoring another individual in the home-based care or even the patient themselves should look out for. So the danger signs include rapid breathing. If your breathing gets worse, if you're an adult and you start to breathe and you have a respiratory rate that is greater than 30 breaths per minute, that's already a danger sign. For the children, we know the respiratory rate is according to the age. So for those 1 to 5 years, if the rate is greater than 40, 2 to 11 months if it's greater than 50, and below 2 months if it's greater than 60. So as long as somebody has a tachypnea and a worsened tachypnea above those limits, they should come into the hospital setting. If the patients feel any difficulty in breathing and they notice or the caretaker notices they have chest indrawing or use of accessory muscles of respiration, that means they're dyspneic, they need to come into the hospital. If they have a persistently high fever, okay, they need to come into the hospital. If they are getting disoriented and their mental status is changing, they are more lethargic, they are sleepy, they can't keep awake, then you know that that is a danger sign. They are probably going into cerebral hypoxia and they need to come into the hospital. Excessive weakness and feeling of excessive tiredness is another danger sign. Convulsions, inability to drink or eat are additional danger signs. Then here I just put back the risk groups, patients at high risk for severe COVID-19, so I will not repeat them. Then any individual, a patient with any individual in the household who is at high risk for severe COVID-19 or who has any of the comorbidities listed above should also probably not go into home-based care because you're putting that household member at very high risk for severe disease. So I'm displaying this just again to show you that only the asymptomatic, pre-symptomatic, mild and moderates are fit to go into home-based care, and the others, the severe illness and critical illness, should be in the hospital setting. Please note that many patients are going into small clinics when they feel unwell. And these clinics, some of them are doing good management while others are delaying patients, while others are also giving them irrational kind of medications. So patients end up being referred to the main hospitals when some damage is already done. So it's important that we as community members know that we should be able to go to a reasonable health facility once we feel unwell, so that we don't put our lives at added risk. So at the time the patient has been confirmed to have COVID-19, the health worker needs to have this discussion with the patient about their home, the infrastructure arrangement in their home. For example, how many people share a bathroom? Are there old people in the home or very young children who are going to share this bathroom and the bedroom? So all these things are important for infection prevention and control in the household. And basic support standards in the household are important to discuss with the patient. And this is part of the tool for assessment of the patient. After confirming that they have disease, you confirm if it is asymptomatic or mild to be able to fit into the category of home-based care. And the patient should be able to communicate, because for some patients, and as we said at the beginning of this meeting, with the Delta variant of SARS-CoV-2, we see patients progressing to severe disease very rapidly. So if a patient does not have means of communication, does not have means of transport, we know our emergency system is also having challenges, so the ambulances do not get everywhere. This patient is going to get into severe disease without them getting help in their home. So it's important that as you prepare for home-based care, you also prepare these resources, communication and means to rapidly communicate with a health worker. You look into the accommodation such that if possible, this patient should live in their own room in the house, not sharing a room with other household members to avoid transmission. And in case they have to share a room, at least put the beds 2 meters apart, have adequate air ventilation and flow in the house, have an accessible bathroom and latrine, and if possible, do not share these bathrooms or toilets or latrines with other members of the household. So the patient should be given room, their own kind of facilities to use to avoid transmission to other people in the home. Additional resources, of course, include food and the medication that might be required. As we shall see, it's very minimal medication really required for this category, but it should be in place. Then masks are very important for the patient. Medical masks are not cloth masks, but also the designated caregiver. It's important that even if there may be 2 or 3 or more people in the household, it's important to have only one designated person taking care of that patient. And that person should also wear medical masks, not the cloth masks. And if possible, double mask instead of wearing just one mask. Then have the IPC supplies available, of course, water, soap for hand washing, alcohol, hand rub, and disinfection of the surfaces is very, very important. So it's important to have things like Jik available and sanitizer. Then the dedicated caregiver to monitor this patient. All know that oxygen saturations can start to reduce at any time for these patients. So if possible, for many households, it's good to have this pulse oximeter in the home to monitor oxygen saturation so that you're able to detect when to take this patient home. It's important, to the health facility. It's important to note that the clinical parameters will tell you when the patient is getting into respiratory distress, but they are not as accurate as the measurements obtained from the pulse oximeter. So if possible, a pulse oximeter is important to have. Then of course, arrangements for evacuation in case there's need. Then just to caution you, patients with COVID-19 may look well, but they may be severely hypoxemic in the home. They are chatting, they are WhatsApping, they are watching a movie, but they are getting into hypoxia. And it's only with your pulse oximeter that you'll be able to detect this. So let's take note of that and take extra care when we have patients in the household. And this category of patients here on this slide should not be delayed. They should immediately be evacuated to be able to receive oxygen in a health facility. Please do not insist on giving oxygen in the home. Why? Because you will not know when to escalate your oxygen dose, when to change the oxygen delivery method. We've seen many patients receiving oxygen through nasal prongs in their home, yet they may actually need a better delivery system for oxygen. So let's desist from keeping patients on oxygen in our homes. If it's an adult and they have very fast or very slow breathing, they are unable to speak, they can't complete a sentence, they are confused, they are sleepy, they are agitated, they are using accessory muscles for respiration, or they are getting blue, they have central cyanosis of the lips and tongue. Those are patients that you straight away know that require oxygen and should be taken to a health facility. Similarly for the children, the same symptoms, very fast breathing, inability to speak, inability to eat or breastfeed for the very young ones, nasal flaring and grunting, use of accessory muscles, head nodding, chest indrawing, intercostal recession, central cyanosis of the lips and tongue, turning blue basically of the coloration of the lips and the tongue, and extreme weakness. These patients should immediately be facilitated to get to where they will be able to receive oxygen. So for measurement and monitoring of oxygen levels, as I said, the breathing rate, the clinical signs are not as reliable as they're not very reliable indicators of hypoxemia compared to the oxygen saturation measurements. So we can use them if we don't have a pulse oximeter, or if we can afford to get the pulse oximeter, we should use them in combination with the pulse oximeter reading. So this is the picture of a pulse oximeter. I'm sure many of us have it in their homes now. Place it on the finger. The middle finger is good enough, is a more objective finger to use. It's important to note for ladies who have nail polish, especially the thick nail polish, the pulse oximeter may not be able to detect oxygen saturation, or it may give you false readings of oxygen saturation. Once you place it on, wait for about 4 to 6 seconds before you can read off. Wait for the patient to stabilize, but also ensure that you have placed it on correctly. Oxygen saturation above 95 is good, 95 to 100% is good, but for patients who have been desaturating, it's important to keep them in a target of 92 to 96%. Anywhere below 92 or even 94%, please take notes that you should take action immediately for that patient. Okay, so for mild COVID, as I said, the presentation and non-specific symptoms, fever, fatigue, weakness, cough, which may initially be dry, eventually becomes a bit productive with sputum, then weakness, malaise, muscle pain, sore throat, nasal congestion, anosmia, a bit of dyspnea, not as severe as the one I've just described. These patients are fit to be called as mild COVID-19, and I'm just going to tell you the treatment that you should give them. It's not too complicated. I know that people out there are giving all kinds of therapy, but for this category, we are giving paracetamol, and if it's an adult, 1 gram of paracetamol 8 hourly is enough. We add adjunctive treatment, that is the zinc, because it has immune modulatory effects, although these have not been demonstrated conclusively, but we know that zinc is an immune modulator. It also improves the repair of tissues and the healing. So at a dose of 20 milligrams once daily for 14 days. Then for patients who are demonstrated to be deficient in vitamin D, or for those older people who are always indoors and we can give empirically, we can give vitamin D at a dose of 1,200 milligrams daily for a month. So please remember that this vitamin D is not to be dished out to everybody, but for patients who meet that criteria. Then because patients may have congestion, nasal congestion, we can use over-the-counter nasal decongestants. And for those who have cough, initially it is distressing cough, we can still use over-the-counter antitussive medications. There are some natural products on the market out there for cough, but products, the medicines containing dextromethorphan are good, or ambroxol. Similarly for children, it is the same. What differs is the dosages. So for example, we know paracetamol in children is given at a dose of 10 to 15 milligrams per kilogram. Similarly for zinc, if a child is less than 6 months, we should use smaller doses of 10 milligrams. Then the recommended home remedies include warm tea made of honey, ginger, garlic, and citrus fruit juice, lemon, orange, tangerine are very good because they contain a lot of vitamins and vitamins in particular. So basically that is the treatment for mild COVID. Please note that on this slide, I haven't included anything like dexamethasone, and I haven't included anything like Clexane because it's not indicated for that category of patients. As you give them those treatments, it's important to monitor patients for danger signs. So what do we monitor? We monitor the breathing according to what I discussed. We monitor presence of fever, so we monitor the temperature. We monitor their mental status for any disorientation. We monitor for presence of any lethargy, weakness, that kind of thing. We monitor how they are able to drink, to stay awake, to stay seated up, or to walk around. If at all they get a convulsion, the color of the lips, the fingers, the tongue, just in case they are getting into hypoxia and turning blue. Then we monitor if they're vomiting or having diarrhea. And then of course we monitor their oxygen saturation using the pulse oximeter to keep it to the targets that I mentioned. Then the household members and caregivers I mentioned should wear face masks, and these are medical masks, not the cloth masks. The designated caregiver should not attempt to wear cloth masks, otherwise they will also come down with infection. Where possible, they can have gowns, but where not possible, the masks and gloves alone when they're caring for their patients are adequate. And these should be removed and disposed of as soon as they are leaving the rooms. They should not be reused. We've seen in the communities people wearing a pair of gloves and using it for a full day caring for a patient, even in the hospitals in some settings. And that is a wrong practice, which just promotes spread of infection. Then eye protection is important. In addition, if you've worn the mask over the mouth and nose, the shield gives added protection for splash kind of exposure. So the shield alone without a mask is not protective. The shield just gives added protection over the mask for splash protection, especially those who may not have goggles. Where possible, you can wear goggles to protect the eyes. Then important to wash the hands for at least 20 seconds after each contact. Use the alcohol-based hand sanitizer that contains at least 60% alcohol, not any sanitizer. Then if that is water is available, it's preferable to use your water and soap. Do not share personal items like towels, dishes, utensils before proper cleaning. Do not mix the patient's laundry with the rest of the household laundry. If possible, wash the patient's clothes on their own, or the patient should wash their own clothes where possible if they're not too sick. If they are very sick and you have to wash them and they are soiled, it's preferable that you soak them. You wait for about 2 days before washing. And when you wash, first soak them in hot water, or if you're using a washing machine, use the highest temperature possible on your washing machine to wash. For other touch surfaces, frequently disinfect these and restrict contacts to minimum number of caregivers, as I said, most preferably one designated caregiver. So this is a summary of the home-based care management. I talked about the pulse oximeter, the masks, opening windows, isolating the patient, or sharing a room to have maybe 2 meters apart. It's important to stay hydrated, just to drink enough. Then the fever medications, paracetamol is preferable. That is acetaminophen preferred to the NSAIDs. But where the acetaminophen is not bringing down the temperature and you have to use NSAIDs, please ensure that you have good hydration, because we know that these NSAIDs have injuries on the kidneys. Then monitoring oxygen saturation, keeping the levels above 92%. If you're in a setting where there is no quick ambulance care, I think it's even preferable to keep it above 94%. The prone maneuver, yes, is good because it improves oxygenation and gaseous exchange. If a patient has been lying on their back, we know the effect of gravity. If their lungs are already affected, as I showed you, some mild patients will still have lung infiltrates and some fluid. So the fluid will gravitate to the dependent areas. So proning helps to get this fluid to get the lung tissue, to relieve the lung tissues of that effect of that damage and fluid by gravity by changing the position. So every about 30 minutes to 2 hours, you change the position. If they were lying on their back, you let them lie on the stomach or the abdomen, in layman's language, but on the abdomen to improve lung oxygenation. Then after another 30 minutes to 2 hours, turn them to lie on their left-hand side. Then after that, turn them to lie on the other side until you complete the cycle back to where they were. So this is very good for improving oxygenation. Then inhaled budesonide. Budesonide is a steroid that can be given as through an inhaler, twice daily. Has been shown to be beneficial in the early course of the disease. So if possible, you can also get this budesonide inhaler for use for patients with mild disease, mild to moderate disease. The oxygen I talked about, and I said, please let's desist from giving oxygen at home, but let's monitor the saturation at home. So as soon as we detect hypoxia, decreasing oxygen saturation, we rush the patient to hospital. Dexamethasone, I said, is a steroid. Other steroids available include things like hydrocortisone, prednisolone, prednisone. These are all steroids. They are anti-inflammatory drugs, but they have dangerous effects if taken. So we are not recommending them for patients who qualify for home-based care. That is patients who have mild, moderate, and those who are asymptomatic. Please do not give them dexamethasone, which is a steroid, because they're going to come down with diabetes, they're going to come down with infection because it lowers their immunity, so they will come down with other bacterial infections. They might even come down with bacterial pneumonia, worsening the already existing COVID pneumonia. Then other drugs, I talked about remdesivir, that may shorten duration of symptoms, but does not decrease the risk of death. So this remdesivir was shown to reduce hospital stay, but not reduce the mortality from COVID-19. In other areas like the United States, it's approved for use. It's not in our national guidelines for use for patients with COVID-19, but I know that some health facilities are using it, and that is partly driving the cost of treatment. Then we also know tocilizumab, we should only be given with under supervision of a physician in patients with severe illness. It's not here, it's being used elsewhere, but it's not part of our national guidelines. Then there are other treatments that are not routinely advised, that have not been shown to work, or those that have been shown to be risky, and others that are still undergoing clinical trials. Drugs like ivermectin, there's literature on ivermectin that has shown that it's not beneficial. There's an ongoing trial here in Entebbe Hospital, clinical trial for ivermectin for treatment of COVID-19. So we wait to hear their results, but it's currently not part of our treatment guidelines. Then we have hydroxychloroquine, the long contested hydroxychloroquine. We performed a clinical trial here in Uganda, and we found that hydroxychloroquine was not beneficial for treatment of COVID-19, although it was actually safe, contrary to what had been shown elsewhere, but it was not beneficial for treatment of COVID-19. So it's not part of our treatment guidelines. And although hydroxychloroquine had been distributed to health facilities, it has been pulled out of the guidelines and of the health facilities. Then convalescent plasma, we also performed a trial here in Uganda, and also trials from elsewhere. Reports have been released showing that convalescent plasma is not beneficial, but high titer plasma might be beneficial, but it's not available in our setting. Other drugs that are not routinely advised, we pulled out vitamin C from our guidelines, so it has not been shown to be of benefit. So it's not part of our current treatment guidelines. Vitamin D, as I said, would be good for only those patients who have been demonstrated to be deficient in vitamin D. Or if you can't do the lab tests for serum vitamin D levels, you can give empirically to those like the very old who keep indoors and do not have enough vitamin exposure to sunshine and therefore are vitamin D deficient. Zinc is still part of our guidelines, mainly because we still think it's beneficial in terms of repairs and immune modulation. There are other drugs, I think I don't have to go through all of them that you can see there on the slide. The discharge criteria. So, sorry, on the previous slide, there's azithromycin. So azithromycin is an antibiotic. It's not an antiviral drug. So we're not giving it to patients with mild symptoms. If a patient just has a bit of a dry cough, they're having weakness, they have tested COVID-19, positive for SARS-CoV-2, they may not necessarily, they don't need azithromycin, but patients who demonstrate and have been assessed by a clinical worker and they have assessed them and they have a pneumonia will benefit from antibiotic therapy. So once a patient has been in the home-based care setting, how do we decide to discharge them? We can discharge or de-isolate a patient from home-based care if the patient stays asymptomatic or stable with mild symptoms in the home. They will be advised to continue the isolation in the home until they meet the following criteria. So, one, if they are asymptomatic and they have completed 10 days from the date of their initial COVID-19 positive test, they can be discharged from the home-based care setting. They can be allowed to continue with their normal activities. So please note that we are not advocating for repeat SARS-CoV-2 PCR tests, and patients can be allowed to continue their activities after the 10 days from the date of their initial positive test, if they were asymptomatic. Then for patients who developed symptoms but had only mild symptoms, and these are the categories that we have been talking about, at least 10 days from the day the symptoms started, and if they have had no fever for another at least 24 hours, they can be discharged to continue with their normal activities. So WHO recommends a minimum of 13 days, that is 10 days after the onset of symptoms, plus 3 additional days without symptoms, just to be sure that this patient is safe to interact with other people. It's important to care for patients' mental health while in the home-based care setting. I know COVID-19 has caused a lot of anxiety to the community, but it causes a lot of anxiety and stress to the patients themselves, more so because of what the patients have been reading, they've been seeing on the TV, they've had people dying. It's important for us to reassure these patients to relieve their stress and anxiety. More so because we know that 80% of patients, even if they have tested positive for SARS-CoV-2, they will either remain asymptomatic or only develop mild symptoms. So those in the home-based care really setting who have been assessed for fitness for home-based care and they're having only mild disease or asymptomatic, we should allay their anxiety. We should portray a positive image of those who have recovered from COVID-19 so that these patients do not go down with other mental health issues. It's important that if you have tested positive and you're in a home-based care setting or even in a hospital setting, it's important to seek support. I've seen numbers flying around on WhatsApp for psychosocial support. Telephone numbers have been provided. You can call those numbers for support. These are numbers to call for mental health workers. But the community also can give you support. Those who have recovered from COVID-19 are additional individuals to give testimonies and support others that are down with COVID-19. Other sources of support include religious leaders and friends and elsewhere. Then it's important to live a healthy lifestyle, eat a balanced diet. Our food here in Uganda contains very good nutrients, good amounts of nutrients, so a balanced diet is good. It's important to stick to eat your 3 meals, at least the 3 meals, breakfast, lunch, and supper. Ensure a good hydration status because your body is in a very highly metabolic state trying to get all this out, and therefore it needs good nutrients, good immunity, and good hydration status. Sleep hygiene is very important. Please get enough sleep. 7 to 9 hours is the recommended duration for sleep for all of us. Get enough physical exercise. I know some patients who have lung injury may not necessarily be able to tolerate exercise. They have effort intolerance, so they can start small. Initially, they may not be able to, but once they start to recover, start with mild exercise as you step it up. Cognitive exercise, intentional unplugging of electronic devices, and practice relaxation techniques. So these electronic devices are good, but if we use them too close to our bedtime, they may not be good because of the light that flashes in our eyes, but also because of the messages that we are reading. So they will cause you a lot of anxiety. Then relaxation techniques are very important. The mental health workers know this better than me. Things like deep breathing, taking these deep breaths, meditation, those are very important relaxation techniques that help us to care for our mental health. Then avoid substance abuse. As I mentioned, smoking is not good. It does not really mix well with COVID-19. So we should endeavor to avoid that, avoid too much alcohol use and medication overdose. The challenges we have seen so far with patients coming in, just a few of them: poor health-seeking behavior. Patients get fever, they get a bit of cough, they get congestion, they stay home, they are steaming, they are taking a lot of ginger, garlic, and honey, and they're staying home, they get very congested. By the time they come, they are desaturating at 70%. And soon they're getting into a critical disease and requiring intensive care unit kind of support. So poor health-seeking behavior, we should all speak to our communities where we live to improve our health-seeking behavior, to avoid this delay in seeking care. We also know that the current dominant variant, the Delta variant, has increased transmissibility. It causes more severe disease with faster progression to severe and critical disease and death. Therefore, it is important for us to overcome this poor health-seeking behavior, and important for us to be able to evacuate our patients as fast as possible to a health setting where there is need. But as we transport patients, it's important to ensure that we stabilize them before we communicate to where we are taking them so that they are received, but also to ensure that we have enough oxygen during transportation. We have seen patients dying in ambulances because they have run out of oxygen or any other medications that may be required in transit. So this lack of an efficient ambulance and emergency care system is also a very critical thing to look into. The referral system, then irrational use of medicines. People are using antibiotics irrationally. I've seen patients who are receiving, they first take 10 days of azithromycin, they go to the health facility, they give them 5 days of ceftriaxone, they give them another 10 days of meropenem, they stop that, they give them PISA. So there's so much irrational use of antibiotics. By the end of this COVID-19 pandemic, we shall have another pandemic of antimicrobial resistance because of this irrational use. So let's try to, as much as possible, avoid use of medications where they're not required. We also have a lot of misuse and overuse of steroids, such as dexamethasone. Patients, as I demonstrated, this dexamethasone trial showed that dexamethasone was beneficial for patients who had severe illness requiring oxygen therapy. So any patient less ill than that, with mild disease, does not require dexamethasone. Dexamethasone, as I said, has its challenges of hyperglycemia, immune suppression, and so many other things. So we should move away from irrational use of dexamethasone. The home-based care use of oxygen with lack of knowledge of how to administer this oxygen and how to monitor the oxygen therapy is also causing another problem. A patient desaturating, requiring 20 liters of oxygen per minute is put at home on nasal prongs, and they're giving them 3 liters of oxygen per minute. How is that patient going to survive? So let's move away from this kind of irresponsible behavior. So I have cautioned you on dexamethasone. This slide is just to show you how to prepare disinfectants in the home, and I'll not go into details, just if somebody is interested, I can share it with them. Finally, I want to talk about preventive measures. Let us all get the vaccine. We know the vaccine is available, so at the earliest opportunity, please get that vaccine. And then let's continue with all the other SOPs as we know. I will not repeat all of them. Thank you very much for listening, and we can have a discussion. Dr. Ekirapa, over to you.
Thank you so much, Professor Pauline. This has been very, very informative. Participants, if you can join me in giving a hand clap to Professor Pauline virtually, yeah, that will be great. Thank you so much. So
thank you, Pauline.
We did not. Yes, thank you, thank you. We did shorten the presentation because we felt that everything shared is really the kind of information that we needed. But that means that we won't have a lot of time for the questions. I'm going to request that if you have a question, you put it on the chat. We shall not be taking live questions. Professor Pauline, I just want to check with you. Are you able to give us another 20 minutes? I know we should have ended by 2:30, which is about 2 minutes away. Are you able to give us another 20 minutes to answer some of the questions?
Yes, Dr. Kirapa, we can have a discussion.
Okay. Okay, so unfortunately, several people were not able to join this presentation. The Zoom link that we had could not take on very many people. And so we are going to ensure that you can be able to access this information online. I don't know if Davidson is able to communicate how we shall do that so that you can recommend to other people who wanted to listen, how they can be able to get access to this. Davidson, are you able to comment on that?
Thank you, Doctor. Hi, everyone. We are going to share this with everyone on email, those who registered in chat. As long as you shared an email, we are going to share with you. But also, we are going to share this on our platforms, the social media platforms for the School of Public Health. If you could look out for them on Facebook, and then also we have a YouTube account. So we are going to share and populate. At least you won't miss out any of these. Thank you.
Okay, so thank you, Davidson. So we shall be sharing the presentation. So Professor Pauline, several questions have been Sorry, I got muted. So I mentioned that several questions had been asked. Some you had already answered. There was someone who was asking about oxygen for home-based management. In your presentation, you tried to discourage that. Someone was also asking about stigma and home-based care. And you mentioned some of the things that we can do to help deal with the stress of having COVID-19. In addition, of course, to giving appropriate information. There was a question that you should comment on the drug natural chemotherapeutics research lab that the president opened, which I thought you may not be in position to answer, but just in case you can be able to respond to. So specifically, people had some questions. I'll give a few and then you can respond and then we can ask some more. We'll just, keep them short. So someone was asking if someone has been sick and tested positive, how long does it take for them to turn negative? So if someone tested positive and they've got treatment, how long does it usually take for them to turn negative? Then someone else wanted to know the outcome for the critically ill patients. You said about 5% of patients will require ICU. They wanted to know what the outcome has been. And then someone wanted to know the minimum number of radiology tests that should be done. You talked of chest x-rays, you talked of chest CT scans. Chest CT scans are commonly used, but they're also particularly expensive. How necessary are they? So the minimum number of radiology tests that should be done. And then someone was asking about the evolving changes in clinical signs and symptoms with the emergence of the Delta variant. So you mentioned a range of signs and symptoms has that changed with the Delta variant? And then lastly, is there room for low-dose aspirin as a prophylactic measure? So when does someone turn negative? Outcomes for critically ill patients, minimum number of radiology tests, evolving changes in clinical signs and symptoms with the Delta variant, and then low-dose aspirin as a prophylactic measure. We can start with those ones. Over to you, Professor Pauline.
Thank you, Dr. Byakika, for the comments and the questions. The first one was, how long does it take for an individual to turn negative? So on average, I think, okay, basically, before I talk about the average, patients take, depending on patients' immunity, what they have received, it's variable from patient to patient. So you can't say it is 8 or 10 days or 12 days for everybody. But on average, and considering the data that has been shown elsewhere, and even the data from our own Mulago Hospital in the previous wave, majority of patients turned negative around day 8 and day 10, on average day 10. And that is why our discharge criteria is at day 10, because most patients were shown to be negative around that period. But we have also seen patients who continue to test positive long after the day 10, even 2 weeks later, or some patients even showing much later and they're still positive. But we think, and the thinking on the explanation is that they are probably still testing positive with dead virus and they are not infectious at that point in time. So maybe just to answer your question with one answer, it varies from patient to patient with an average of about day 10. Outcome for critically ill patients, this is also very, very variable depending on the setting. I'll refer you to an article that was published in, which journal was that? It was the ACOS paper trial. And this is a paper from Critical Care Society of Southern Africa. This paper showed that this paper was published in the Lancet early this year. And this paper showed that there was the mortality in critically ill patients with COVID-19 is higher in African countries than what is reported elsewhere, like in North America, in Europe, or South America, and even Asia. And the increased mortality was associated basically with insufficient critical care resources, as well as presence of comorbidities that I talked about, HIV/AIDS, diabetes, kidney disease, liver disease, as well as severity of organ dysfunction at admission. So there was higher mortality amongst patients in African countries. For Uganda alone, we have not, there's no data published or released yet on the proportion or the mortality rates amongst patients in the intensive care units. So, but we know that the mortality is quite high, okay? So I think that summarizes it. I won't put a figure to it, just in case I quote it out of context or I get misquoted. But we also know that there are many factors that are influencing the mortality of these patients in the critical care settings, in the ICUs. I think all of you have seen a discussion going on WhatsApp, in the media, including both paper and televisions, about critically ill patients in the ICUs and the cost drivers and some of the outcomes. So there are a multitude of factors that are affecting our critical care of patients in Uganda. And I think that's a very long discussion that I probably do not want to go into at this point in time. but could be discussed at a later date. Then the other question was minimum number of radiological tests to perform. So it's good practice really at baseline. If you receive a patient in the health facility, in a hospital or wherever you might be, it's good practice to always have baseline tests. So I haven't indicated the hospital management because this was basically for home-based care. And for home-based care, as part of assessing a patient for fitness for home-based care, you might do maybe a minimum, an X-ray, or if the patient has resources, they might do a CT scan. But it's not important to keep repeating it over a few days or hours, as some people might want to do, because we also know that the lung, if there was lung injury at baseline, it's also going to take a while to recover. So if you repeat a CT scan after 4 days, what are you trying to show? Unless you're talking about pulmonary edema. But if you're talking about real infiltrates, it may not be necessary to repeat. I think I personally probably would repeat maybe after 2 weeks or at discharge, something like that, to show baseline, and then after treatment at about 2 weeks or 10 days, something like that. But there's no minimum number prescribed. But at the same time, I would say that having too frequent of them would be probably a waste of resources and increasing the patient's bill for nothing. Then in terms of clinical presentation, as I presented, COVID-19 is majorly a respiratory system disease. However, it can have multi-system effects as shown in the slides that I presented, because of the underlying pathophysiological mechanisms. So patients' symptoms and signs are not only restricted to the chest. We have seen patients coming in with new onset strokes because of the thromboembolic kind of the thrombosis that happens from their hypercoagulable states. So the clinical presentation is varied and any system can be affected, as I showed in my presentation. Low dose aspirin, I haven't seen any documented literature to support use of this except what I saw, I think, in the newspapers. So I can't really speak much about that. But also the mechanism of aspirin and the mechanism, the hypercoagulable state of COVID-19 do not seem to be in line. So it's preferable to use the low molecular weight heparin, the Clexane, for treatment and prophylaxis for this hypercoagulable state. And as prophylaxis, use of aspirin is not a practice that we are doing currently, and I don't have any literature to back that up, but there is literature to back up use of low molecular weight heparin. I think those are the questions.
Thank you. So the next, there are quite a number of questions related to vaccination. Some people, someone was asking, some people develop severe sickness after vaccination. So what are the causes of this severe sickness? How can this be solved? Then is it recommended that people test for COVID-19 before vaccination? Some people have also said if you have already acquired COVID-19 and then you get your second jab, you may not fare very well. So should those who can afford test for COVID before they get their vaccinations? And then how long after you've tested positive should you get vaccinated? So that was why do some people develop severe sickness? Should you test before you get vaccinated? Then if you test positive, how long should you wait before you get vaccinated? Then there were questions we knew we were not going to be able to avoid. People are asking about COVID-19. What do you say about COVID-19? Should they use it at home? Generally, what do you say about COVID-19? And also steaming. Is steaming recommended and with what? So after that, we just have 2 or 3 and then we shall round up. So the vaccination, COVID-19 and steaming.
Okay, thank you very much, Dr. Ekirapa. Yes, the questions about the vaccine. It's important for all of us to know that the vaccines do not contain virus. They don't contain SARS-CoV-2, okay? That is the bottom line. So we should not fear this vaccine, okay? The vaccine should not be giving you COVID-19. That is not there at all because it doesn't at all contain the virus SARS-CoV-2, not anywhere at all. The vaccine is made to stimulate your body to produce these, I talked about the neutralizing antibodies, that the immunological reaction to prevent you from coming down with disease with COVID-19, okay? So it's actually a vaccine made out of a recombinant chimpanzee adenovector. As the name suggests, the name says the ChAd OX, the ChAd is really the chimpanzee adenovector. You know, so this vaccine does not contain the virus, and therefore we should not be worried that it is giving us the disease COVID-19. It's not possible, okay? The vaccination, after getting a vaccine, just like any other vaccine, if you have been given any other vaccine before, we normally get, especially the children, they'll come down with a fever, they feel weak. Those are usual reactions to the vaccine. And that should give us courage to know that actually this vaccine is stimulating my body in one way or another, okay? Those are usual reactions, so we shouldn't fear. It shouldn't cause us to worry. Should you test for COVID before vaccination? As I said, this vaccine does not contain the virus. I think currently we don't have guidelines on whether you should test for COVID before vaccination, but if you're asymptomatic, I mean, if you don't have any illness, I don't think it's important for you to test for COVID before vaccination. What I think is important, if you're feeling unwell in this era, you have a headache, you have fever, you have joint pains, you're feeling unwell, go test for COVID and know if you have COVID early enough and seek the right treatment, okay? But otherwise, it's not current Ministry of Health policy for you to test for COVID before vaccination. There was a question, how long after testing positive should one get the vaccine? I think the Ministry of Health has rolled out some guidelines that were circulating on WhatsApp, and we can share with you those guidelines. But we know that once you're sick with COVID-19, your body is stimulated, once you're infected with the virus and you're sick, your body is stimulated to produce these antibodies. How long the antibodies last is still a question for research, but I think some studies have shown antibodies to last as much as 6 months, others as much as 9 months. There's varied literature out there. So if you have suffered you're sick with COVID, it's good for you to recover and then get the vaccine out, later. Some people think that even one dose, if you have suffered from COVID, may be sufficient, but it's not conclusive. But as I said, the PS passed around some guidance on that one, and we shall be able to share with you that guidance. I know that currently first dose vaccine is not available except for health workers. So if you have had COVID, there may not be an emergency for you. You've been sick, you're discharged from hospital. It's not an emergency for you to rush and get the vaccine because you still have some antibodies circulating in your system that is preventing you from getting down with COVID. But you should eventually still get the vaccine, and you can get the vaccine later as the PS guidance will show. I don't remember what the Ministry of Health guidance has said. Dr. Kirapa, I don't know if you saw that recent guidance, but the literature has shown that even up to 6 months, antibodies still are in circulation. Then regarding UBV01, the natural product that the president launched, yes, this trial is ongoing. It's actually in almost the final stages of implementation here in Mulago Hospital and in Nambole. And we shall be able to get those results out very soon. It's a natural product named UBV01, and the clinical trial is ongoing. Covidex, I don't have much to say about COVID-X, but I know that NDA gave that notification, meaning it is a supplement. It's not a bullet, it's not a magic bullet for treating COVID-19. It is the literature out about COVID-X shows that it's supportive therapy, it's a supplement. And I know that a trial is soon to start on COVID-X, and that will give us more information. So I can't speak much about COVID-X. Then about steaming. So if you have pneumonia, steaming will not help you, you know? So if you're sick, you're down with pneumonia, you're in the home, you're running a fever, and you're basically steaming, you're doing yourself a disservice. I know steaming might relieve a bit of nasal congestion here and there, but it's not going to cure the virus. And if you have lower respiratory tract symptoms, it's not going to help you. Additionally, some people are using very hot water, steaming hot, covering their heads in jackets. Others are putting themselves in tents, closed up with zippers. That is very dangerous practice because you're going to burn yourself, you're going to get scalds, you're going to burn your airway. So it is very, very dangerous. So people need to be cautioned on that kind of steaming. If you're just steaming for nasal congestion a little bit with, I don't know, with whatever natural products, it may give you some relief from that congestion, but it's not going to cure you from COVID-19. And it's not going to help you for lower respiratory tract disease. So if you already have a pneumonia, it will not be of any benefit. Over to you, Dr. Kirapa.
Okay, thank you. So these are the last set of questions we are taking, and then we close. The questions about the number of tests we already answered. There was just one more question about vaccines. Can I change to another vaccine if I got AstraZeneca and it's not available? Can I change and get another one? And then if I miss my second dose, you know, after the recommended 2 to 3 months, you know, 4 months pass, do I start afresh with the vaccination process? So can you change from one vaccine to another? Then if you miss your dose, second dose within 3 months, should you start afresh? Then someone wanted to know, should they disinfect the home after they've had a patient? Then someone else was asking, what are the recommended non-steroidal anti-inflammatory drugs that can be used for managing COVID? Then someone was asking if there is some people get blurred vision, COVID-19 patients, when they don't have diabetes. What could be the cause of that? And then these are really related to the challenges we are facing in our health system. What is in place to promote the clinical evaluation that you were talking about after people get results? And how can we keep the costs manageable? Do you have any advice? Someone noted that an initial clinical evaluation may take 200 to 300,000. Is there any way we can keep the costs manageable? So there was a question on costs. There was a question on that initial clinical evaluation. Are we doing anything to ensure that happens at the various testing sites? Then blurred vision, what is causing that? Change of vaccines. Then if they miss their second dose at 3 months, non-steroidal anti-inflammatory drugs that they can use, and then disinfection of the home. So we shall not be taking any more questions after this. So thank you, that's the last round.
Thank you, Dr. Kirapa. Those were very many questions. I don't know if I got all, but I'll try to remember. If I don't remember, you can help me. I think you asked about mixing vaccines. I saw some literature recently, and I may not be in the best position to answer that question, but some literature showed that getting one vaccine, for example, the AstraZeneca, and then you get another vaccine, another type, Pfizer or something, actually had good effects in terms of the immunity. But I didn't read the whole paper, so I will not be very bold on that one. When to get the vaccine after COVID illness, I think I answered that. Initially, I think some literature has said as soon as you recover, within 3 months, get the vaccine. But I think the PS changed that, especially now that we don't have vaccines for everybody. So that guidance, as I said, I'll look it up and share. Then is it important to disinfect the home after? It's, as I said, if there has been a patient or if there's a patient in the home, disinfecting surfaces, especially where the patient lives, is a very, very good habit, because we said that if a patient sneezes and their droplets are falling on the tables, the virus is able to survive there for a number of days, up to 6 days. So disinfecting the surfaces and disinfecting the room and the bathrooms where this patient has been using would be a good practice. And I showed you how to dilute the disinfectant, the jig and other bleach, other chlorine that you could use to disinfect surfaces in a home. So it's a good practice. The other question was about which NSAIDs to use. So we know NSAIDs are non-steroidal anti-inflammatory drugs. There are very many out there. But as I said, the preferred antipyretic for these patients is acetaminophen, which is paracetamol. It's only in those cases where paracetamol is not helping you to really do what you need them to do in terms of bringing down the fever and a bit of anti-inflammatory that you need to use the NSAIDs. So there are NSAIDs like Brufen, like diclofenac that you could use, but there are very many out there. However, as I said, it's important to know that these have effects, especially on our kidneys, on patients' kidneys. So if a patient is dehydrated and you're busy dishing them diclofenac or Brufen, you're causing more kidney injury and you may throw this patient into more damage. I don't remember the other questions, Dr. Kirapa. I think I'm tired. I don't remember. Oh, you said clinical evaluation. Yes, as I said, it's important for patients. Once you get your COVID, your SARS-CoV-2 positive test, and you have some symptoms, and you're going into COVID home-based care, you're doing yourself a disservice if you haven't gone to a doctor to assess you or a health worker to assess you and tell you the category of disease you have, because you yourself will not know if your blood pressure is high, if your blood sugar is out of range, if your breathing is difficult, if you have crepitations in the lungs, if you have tachypnea, if you have tachycardia, you will not be able to tell. So being assessed by a medical worker, a health worker, a clinician is very, very important as a first step to you getting good treatment outcomes. If you simply go into your home-based care, but you're slowly getting into, you're slowly going into hypoxia, you have a pneumonia already, and you're going to go home and dish yourself with garlic and I don't know, whatever concoction, you're doing yourself a disservice. So the initial clinical assessment is very important, and the guidelines stress that. Dr. Kirapa, I think I have forgotten the other questions.
There was just one, you actually answered all of them. About the vaccine, you know, there's a period within which you should get the second dose. So for example, right now we don't have probably enough vaccine for everyone to get their second dose. So if people, you know, take longer than 3 months, so longer than the recommended period, do they have to start dose 1 again?
I don't think I have an answer to that question. When you're saying if you have taken longer than 3 months,
recommended,
you got the first dose, but you have taken longer. The literature currently says that after the first dose of the AstraZeneca, you should get the second dose 8 to 12 weeks later. And the longer, the better towards the 12-week period. The literature suggests it's better. But if you have gone past 12 weeks, I think as soon as you remember, you should be able to go and get your second dose. It shouldn't be, because 12 weeks really is 3 months, and that's what the person is asking about, 3 months. You should be able to get your second dose at that 3 months interval. And you don't necessarily have to repeat if it's at the 3 months interval, the 12 weeks. That's my thought, but I could also look it up. There's a lot of unknowns really, and we can keep reading to get more and more answers.
Okay, thank you. I guess what is pushing that is the fact that not everyone who got a first dose may be able to get the second dose, but that gives us guidance and we'll keep our eyes open. So again, Professor Pauline, I want to thank you for a very informative presentation, for answering the questions that we have had. These are one of the first seminars I've attended where up to 2 hours after people are still looking to join, which shows there was a lot of demand for the session. So we want to thank you so much. So we are drawing to a close, but I see a hand. I know Dr. Nachigozi works with the Ministry of Health. We are not taking questions, but this may be particularly important. So I'll just give Dr. Harriet an opportunity before we close. Dr. Harriet Nachigozi.
Hello,
yes.
Thank you so much, Doctor. It is really a pleasure to attend this meeting. I had a concern that much as we are doing home-based care for COVID, it is very important to keep near the doctor. At least you have a reliable doctor on call. I must say that I'm a COVID survivor, and I've seen it that it is very important that you get support from this medical team. We've been emphasizing the X-ray, but it is also important to check on the morphology of the blood through the CBC counts, and doctors will help you more. Other than saying that I'm having COVID, I'm isolating in my home, you are just taking herbal medicine. Then on the issue of the vaccine, we've seen some cases, and I was reading some literature that of course, there are some good numbers which are rising from people who have been double vaccinated. They have received their 2 doses and they are now dying. There is some literature there. So it is now generating research that probably there is a lot of unknown, which our researchers can tap in. Thank you.
Okay.
Thank you so much.
Thank you, Dr. Nachigozi.
Thank you very much, Dr. Nachigozi, for that addition. It's very, very important addition. And also to mention that I also left out all the other laboratory tests that may be done in the hospital setting, mainly because this session was only for home-based care. But what Dr. Nachigozi says is very important. Thank you very much. There are quite a number of tests that could be done in the hospital setting, including the complete blood count, including assessing your chemistry, the renal function tests, the liver function tests, the D-dimers. As I indicated, these patients are in a hypercoagulable state. Things like inflammatory markers, the C-reactive protein is very important. Although we know that some of them are non-specific tests, but they could give you an indication of how bad the injury is in these circumstances. So there are many other tests that I didn't go into detail because it was on home-based care, and that can be addressed at a different setting. Thank you very much.
Okay. So thank you very much, Professor Pauline. Indeed, this was targeting the general issues, but a lot of information was provided that is important for clinicians as well. Maybe next time we can have a seminar that also focuses particularly on clinical management, which would provide an opportunity to go into detail about some of those issues. Participants, thank you for joining us. I hope that we can all remember the key issues. Professor Pauline stressed that those with severe illness, critical illness, need to be managed in hospital. Issues like their oxygen saturation, if it's below 94%, if they have labored breathing, if their breath count is above 30, that can be some markers for you. In terms of treatment, let's just remember that things like dexamethasone, anticoagulants are recommended for severe cases. And when you test positive, it's best to get a medical evaluation first so that baseline investigations are done before you start treatment at home. And she also shared with us some of the signs that can show you the illness is getting severe: excessive weakness, fever for more than 3 days, difficulty breathing, inability to eat. Let's not just take these as normal issues. It can be a sign of severe disease and we need to get to the hospital. She also mentioned things like communication and being able to refer the person immediately should they be severe. Conditions you need at home: separate rooms, separate toilets, some of the resources that you need, medical masks and not cloth masks, oximeters, an evacuation plan. So I believe that with what we have all learned today, we shall be able to manage our patients better. Like we say, we shall share this presentation so that those who are not able to attend are also able to learn this. So thank you for staying with us. And Professor Pauline, thank you so much for this very informative session. Have a good afternoon, everybody, and keep staying safe. Thank you.
Thank you very much, everyone, for attending the session, and have a good afternoon.
Thank you so much, Dr.
Thank
It's
you.
been nice. Thank you.
Thank you. Have a good afternoon.
Thank you so much.
Thank you.
Thank you
Thank
very
you,
much.
Angela and Davidson, for organizing this.
But doctor, you have not talked about two people who are dying after receiving the COVID-19 vaccine.
Professor Pauline mentioned that the vaccine does not have COVID. It doesn't have the virus.
Oh my God.
So people may die from a number of different things. And often we haven't really investigated these cases fully. We assume just because it happened around that time, it must have been that vaccine, but it may be anything else. It's not proven that it's the vaccine. Yeah.
Thank you.
Thank you, Professor. It's also important in the subsequent probably events that we talk about managing corpses, because people are careless. You see people getting near corpses, yet we are told we are not supposed to. Probably people need to be educated, those who have died from COVID.
Okay, so we shall note that down as something that is of interest.
Doctor, and also a public webinar is needed because this was just a limited number of people and people are out there. They need information.
You recommend we repeat?
Yeah, you repeat, but you increase the participation gap or capacity.
And also we need also to include the Omuntu Wawansi, because the way we are talking about separate facilities. Now, if you go to our slum areas where places are congested, you go to apartments. So we need to organize a webinar which takes into account such settings as well. Otherwise, you are in an apartment, of 2 bedrooms, and you are telling people to separate toilets. People are in Mizigos, in slums. So I think you organize another webinar which really targets this, where the majority of our people are. Otherwise, this one is good for maybe cities in the urban areas, but urban areas in the developed countries. Thank you.
Okay, we shall look in that. For that, maybe a TV thing, maybe like Makerere or something, I'm thinking might be more accessible.
Yeah.
Yeah, perfect. That would be great. That would be great.
Or a radio, because a radio can be accessed everywhere.
Yeah. Makerere, a radio show may be more
concurrently, maybe radio, TV concurrently.
Okay. Thank you.
I have a suggestion. Maybe this is Davidson.
Yes, Davidson.
In addition to the suggestions here, I think maybe we would need to have a seminar on sharing experiences, especially the people who have followed the guidelines and been able to treat COVID at home. I've had quite a number of people talking about the experiences at home, and I think it could be very good and quite inspirational, since at this point in time, we are not sure. You can get it anywhere, and from the reports we see, hospitals getting overwhelmed, it might be something that is unavoidable to treat COVID at home. So some experience, some session on experiences, we can identify some of the people who have gone through this to just share the experiences, so that we can also have, on the other hand, medical experts, but then also the people from the public sharing what exactly they did, how they use it, including, by the way, the myth that we see. If you noticed in the discussion here, people were asking quite a lot about COVID-19. And whereas I understand the gentleman behind it has been asked not to engage further in public discussions, but we have people who have been using this, and they could be quite a good sample to ask around, to share their experiences on what they felt, or what they can say about it. I have personally someone who is an enrolled nurse, and she's been down. The whole family has been down. They are still in self-isolation, the entire family, and they are saying they had to reach out for COVID to ease, I think, their life at home. There could be some good experiences out there. I'm just imagining and thinking.
Okay. Yeah.
People are testifying about COVID. Even me personally, I've used it.
Okay.
But another key thing that we need really to emphasize are these misconceptions, like we talked about steaming. Now, all the families are now doing steaming, but if he has all those complications, we really need to put a lot of emphasis on that. So let's try to identify common misconceptions, steaming, and then overuse of antibiotics, the way you pointed out, and then we really put much emphasis, because there's a lot of misuse, really. Thank
you. Sure, there are lots of unanswered questions, and so information is particularly important.
Otherwise, thank you very much. I appreciate it.
Okay, thank you so much for your feedback and suggestions. We shall see how we can move forward some of the suggestions that you've made, and thank you for responding. If we can have another session that can accommodate more people, we'll look into that. We'll try to do that.
Okay.
Okay. All right.
Doctor, you made a comment on this on my.
No, I am not able to comment on it myself. But if you can give me your address, maybe I could ask Professor Pauline to just give you a response. Can you put your email address so that I get it? I can forward it.
Prof, I've shared it. It's all. That's the main.
There was someone who also asked about diabetes. I don't know if they're still on. They could also give us their address, Cyrus, in.
Doctor, how about these local herbs, the mangoes, mango leaves? Then there is blue potterweed. There are many things. Maybe you can prepare to guide people on what are the most appropriate local herbs which can be accessed from the bushes or from the local trees.
Yeah, I think something on recommended herbal remedies.
Yes.
Would also be good. So we shall note that down as well.
And also you have not thrown more light on this trial natural remedy, the UBV 01.
They said it's a trial that is being done. It's
Yes,
being run at the moment.
yes.
So the details about it are not yet available.
So
Once
it is,
they finish,
Maybe, Doctor, to just expound on that, we've been hearing about this herbal or perhaps trial and even the president keeps talking about it, a local solution for Uganda. But either the scientists have not been given chance to, explain to the public, even calling upon the public to participate in this particular trial. Don't you think it is now time for you to get in touch with the people in charge researching about this trial to give an insight of what they are doing, and so that the nation and perhaps the people in this public health sector can be motivated and inspired about what currently is ongoing?
Okay, we shall look into that.
Okay, then
we shall look into that and see if we can contact them and if they can be available for this kind of webinar to shed more light on what they're doing. Okay, all right. Thank you so much, everyone. Have a good afternoon.
have a good afternoon to Doctor.
Okay, bye-bye. Keep safe.
You too.
As much as you can. Yeah.
Yeah.
Okay, you too, Dr. Chirapa. It was nice.